Welcome to Speechify. Speechify can read to you in the breast is distinguished from other organs by three important characteristics. First, its major function is to provide for the nutritional support and survival of another individual, the infant. Second, it undergoes dynamic structural changes throughout life, expansion of the lobular system after menarche, periodic remodeling during adulthood, especially during and after pregnancy, and ultimately involution and regression. Finally, as symbols of femininity, breasts have social, cultural, and personal importance that is unique from other organs. All of these features impact the origin, presentation, and treatment of breast disease. Understanding diseases of the breast requires knowledge of its normal anatomy and cellular constituents, which include two major structures, ducts and lobules, two types of epithelial cells, luminal and myoepithelial, and two types of stroma, interlobular and intralobular. Each of these elements is the source of both benign and malignant lesions, figure 23. 1. 6 to 10 major ducts extend down from the nipple and branch into multiple smaller ducts and finally terminate as lobules. Superficial portions of the major ducts are lined by keratinizing squamous epithelium that abruptly transitions to a double-layered epithelium, luminal and myoepithelial cells, which lines the remainder of the duct-lobular system. Following puberty, the duct system expands and proliferates, giving rise to numerous terminal duct-lobular units. These units consist of grape-like clusters of small acini surrounded by a specialized intralobular stroma, see figure 23. 1. In some women, ducts and lobules extend into the subcutaneous tissue of the chest wall and into the axilla. As a result, diseases such as breast cancer sometimes arise outside of the confines of the grossly evident breast tissue. Changes in the female breast are most dynamic and profound during the reproductive years. Further branching of ducts and lobule formation occur under the influence of hormones such as estrogen, progesterone, and prolactin. Just as the endometrium grows and ebbs with each menstrual cycle, so does the breast. In the first half of the menstrual cycle, the lobules are relatively quiescent. After ovulation, under the influence of estrogen and rising progesterone levels, cell proliferation increases, as does the number of acini per lobule. Upon menstruation, the fall in hormone levels induces regression of the lobules. Only with pregnancy does the breast completely mature and become fully functional. Lobules increase progressively in number and size. By the end of a full-term pregnancy, the breast is composed almost entirely of lobules separated by scant stroma. After parturition, the lobules initially produce colostrum high in protein, changing to milk higher in fat. 123:38, ret paquet, Sayerb. Nipple, luminal cells, blue. Myoepithelial cells, black, intralobular stroma, green, interlobular stroma, red. Papilloma, DCIS, epithelial hyperplasia, normal lobule fibroadenoma, invasive carcinoma. Phyllodes tumor, hemangioma, angiosarcoma. Normal benign malignant, figure 23.1. The normal cells and structures of the breast, including epithelial cells and myoepithelial cells, intralobular stromal cells and interlobular stromal cells, and large ducts and terminal duct lobular units, can give rise to both benign and malignant tumors. DCIS, ductal carcinoma in situ, and calories over the next 10 days as progesterone levels drop. Upon cessation of lactation, epithelial cells undergo apoptosis and lobules regress, but only partially. The permanent changes that are produced by pregnancy may explain the reduction in breast cancer risk that is observed in women who give birth to children at young ages. After the third decade, long before menopause, lobules and their specialized stroma start to involute, and the interlobular stroma is converted from radiodense fibrous stroma to radiolucent adipose tissue. These changes may be attenuated or delayed by hormones from endogenous, e.g., estrogen from fat stores in obese women, or exogenous, e.g., postmenopausal hormone replacement therapy sources. Disorders of development, milk line remnants, supernumerary nipples or breasts result from the persistence of epidermal thickenings along the milk line, which extends from the axilla to the perineum. Disorders of normally situated breasts only very rarely arise in these heterotopic foci, which most commonly come to attention due to painful swelling prior to menstruation. Accessory axillary breast tissue. In some women, the normal ductal system extends into the subcutaneous tissue of the chest wall, or the axillary fossa, the axillary tail of Spence. Because this tissue may not be removed by prophylactic mastectomies, such procedures markedly reduce but do not completely eliminate the risk of breast cancer. Congenital nipple inversion. The failure of the nipple to evert during development is common and may be unilateral. Congenitally inverted nipples are usually of little significance, since they correct spontaneously during pregnancy or can sometimes be averted by simple traction. Acquired nipple retraction is of more concern, since it may indicate the presence of an invasive cancer or an inflammatory nipple disease. Clinical presentations of breast disease. The most common breast signs and symptoms reported by women are pain, inflammatory changes, nipple discharge, lumpiness, or a palpable mass, figure 23. Few symptoms are so severe as to require treatment, and the primary reason for investigating their cause is to evaluate the possibility of malignancy. Greater than 90% of symptomatic breast lesions are benign. Of women with cancer, about 45% have symptomatic disease, while the remainder come to attention through mammographic screening, figure 23 2b. Among the most common or significant signs and symptoms that bring breast lesions to clinical attention are the following. Pain, mastalgia, or mastodynia is a common symptom that may be cyclic with menses or non-cyclic. Diffuse. CL initial presentations of breast DISE1 Eserose 39. 5% are cancers, 7% are cancers. Nipple discharge. Pain. Inflammation. Less than 1% are cancers. Palpable mass 5% are cancers. Lumpiness or other symptoms 1% are cancers. Nipple discharge. Pain. Abnormal mammogram. Inflammatory changes. Palpable mass. A symptoms of patients B presentations of breast cancers figure 23.2 symptoms of breast disease and presentations of breast cancer. A. Common breast-related symptoms that bring patients to clinical attention include pain, inflammation, nipple discharge, lumpiness, and palpable masses. Although these symptoms often cause concern, they are associated with cancer in less than 10% of affected women. B. Presentations of breast cancer. Cyclic pain may be due to premenstrual edema. Non-cyclic pain is usually localized to one area of the breast and may be caused by ruptured cysts, physical injury, and infections, but often no specific lesion is identified. Although most painful masses are benign, in about 5% of cases the underlying cause is breast cancer. Inflammation causes erythema and edema involving all or part of a breast. This is a rare symptom and is most often caused by infections, which only occur with any frequency during lactation and breastfeeding. An important mimic of reactive inflammation is inflammatory breast carcinoma, discussed later. Nipple discharge may be normal when small in quantity and bilateral. Milky discharge galactorrhea is associated with elevated prolactin levels, e.g. by a pituitary adenoma, hypothyroidism, or endocrine anovulatory syndromes, and also may occur in patients taking oral contraceptives, tricyclic antidepressants, methyldopa, or phenothiazines. Repeated nipple stimulation also may induce lactation. Galactorrhea is not a feature of malignancy. Bloody or serous discharges are most commonly due to large duct papillomas and cysts. During pregnancy, rapid growth and remodeling of the breast may produce a bloody discharge. Discharge associated with malignancy is most commonly due to ductal carcinoma in situ DCIS and increases in prevalence with age. It is caused by an underlying carcinoma in 7% of women under age 60 and in 30% of women 60 years of age or older. Discharge in older women that is spontaneous, unilateral, and bloody is likely to have a malignant origin. Lumpiness, or diffuse nodularity of the breast, usually is a manifestation of normal glandular tissue. When pronounced, imaging studies may be needed to exclude the presence of a discrete mass. Palpable masses can arise from proliferations of stromal cells or epithelial cells and are generally detected when 2 to 3 centimeters in size. Most, approximately 95%, are benign. These tend to be round or oval in shape, rubbery, and mobile, and to have circumscribed borders, the most common benign. Masses are fibroadenomas and cysts. In contrast, malignant tumors invade across tissue planes, are often hard serous in consistency, and usually have irregular borders. The likelihood that a mass is malignant increases with age, rising from 10% for women younger than age 40 to 60% for women older than age 50. Approximately 50% of carcinomas are located in the upper outer quadrant, 10% in each of the remaining quadrants, and about 20% in the central or subareolar region. Although about 1/3 of cancers are first detected as a palpable mass, screening by palpation has little effect on reducing breast cancer mortality. Unfortunately, the majority of cancers that have the capacity to metastasize do so before they reach a palpable size. Mammographic screening was introduced in the 1980s in an effort to detect non-palpable asymptomatic breast carcinomas before metastatic spread and is currently the most commonly used screening test for breast cancer, Fig. 23.2 billions. The sensitivity and specificity of mammography increase with age. At age 40, the probability that a mammographic lesion is cancer is only 10%, but this rises to greater than 25% in women older than 50. The principal mammographic signs of breast carcinoma are densities and calcifications. Densities. Breast lesions that replace adipose tissue with radiodense tissue form mammographic densities. Rounded densities are most commonly benign lesions such as fibroadenomas or cysts, whereas invasive carcinomas generally form irregular masses. The average size of invasive carcinomas detected by mammography is about 1 cm, significantly smaller than carcinomas detected by palpation, and only 15% will have metastasized to regional lymph nodes at the time of detection. Calcifications. Calcifications form on secretions, necrotic debris, or hyalinized stroma, and are often associated with benign lesions such as apocrine cysts, hyalinized fibroadenomas, and sclerosing adenosis. Calcifications associated with malignancy are usually small, irregular, numerous, and clustered. A marked increase in the 1040, Chapter 23, the breast. Diagnosis of DCIS, a form of breast cancer that is often associated with calcifications, was observed after the introduction of mammographic screening. Approximately 10% of invasive carcinomas are not visible by standard two-dimensional mammographic techniques. Causes include the presence of surrounding radiodense tissue that obscures the tumor, especially in younger women, small tumor size, a diffuse infiltrative growth pattern with little or no tissue response, or a location close to the chest wall or in the periphery of the breast. Other imaging modalities can be useful adjuncts in such circumstances, particularly in evaluating palpable masses that are not seen well with standard mammography. Digital breast tomosynthesis, three-dimensional mammography, integrates additional views of the breast and can detect subtle changes in breast parenchymal texture. Ultrasonography distinguishes between solid and cystic lesions and more precisely defines the borders of solid lesions. Magnetic resonance imaging, MRI, detects cancers by the rapid uptake of contrast agents due to increased tumor vascularity and blood flow, and can be particularly helpful in the evaluation of breasts of high density. Although the recent downward trend in deaths from breast cancer is partially attributed to earlier diagnosis due to mammography, the beneficial effect of screening is smaller than originally anticipated for several reasons. By the time of detection, most 70% to 80% cancers are invasive and some have metastasized. Even more troubling, the cancers that are most likely to cause death are least likely to be detected by mammography. These lethal cancers arise in young women of pre-screening age or grow so rapidly that they present during the interval between mammograms. On the other side of the ledger, many cancers detected by mammography are clinically unimportant, being so indolent that they would never have caused harm had they gone undetected, a situation reminiscent of many prostate cancers in men, see Chapter 21. It is estimated that between 10% and 30% of invasive cancers detected by mammography fall into this category. Although this issue is sometimes referred to as a problem of overdiagnosis, it is more accurate to say that it reflects a need for reliable predictors of the behavior of invasive carcinomas. Some predictors of outcome in current use are discussed later. Inflammatory disorders. Inflammatory diseases of the breast are rare, accounting for less than 1% of breast symptoms, and are caused by infections, autoimmune disease, or foreign body type reactions to extravasated keratin or secretions. Inflammatory breast cancer mimics inflammation by obstructing dermal vasculature with tumor emboli and should always be considered in a woman with an erythematous swollen breast, discussed later. Acute mastitis. Acute bacterial mastitis typically occurs during the first month of breastfeeding and is caused by a local infection, when the breast is most vulnerable due to cracks and fissures in the nipples. From this portal of entry, Staphylococcus aureus, or less commonly, streptococci, invade the breast tissue. The breast is erythematous and painful, and fever is often present. At the outset, only one duct system or sector of the breast is involved. If not treated, the infection may spread to the entire breast. Staphylococci infection often leads to single or multiple abscesses, whereas streptococci cause spreading infection in the form of cellulitis. Most cases of lactational mastitis are easily treated with appropriate antibiotics and continued expression of milk from the breast. Only rarely is surgical drainage required. Squamous metaplasia of lactiferous ducts. Squamous metaplasia of lactiferous ducts is known by a variety of names, including recurrent subareolar abscess, periductal mastitis, and Zewska disease. Women, and sometimes men, present with a painful erythematous subareolar mass that mimics a bacterial abscess. In recurrent cases, a fistula tract often develops under the smooth muscle of the nipple and opens onto the skin at the edge of the areola. In many affected women, the nipple inverts due to traction produced by inflammation and scarring. More than 90% of afflicted individuals are smokers. It has been suggested that a relative deficiency of vitamin A associated with smoking or toxic substances in tobacco smoke alters the differentiation of the ductal epithelium. Morphology. The key feature is keratinizing squamous metaplasia, which extends into the nipple duct well past the usual point of transition from squamous to glandular epithelium, figure 23. Keratin shed from these cells is trapped and plugs the ductal system, causing abscess normal, keratin plug, normal duct smooth, muscle of areola, squamous metaplasia extending deep into duct. Fistula opening at edge of areola, double-layered cuboidal epithelium, rupture with inflammatory response to keratin debris, abscess. Figure 23.3 squamous metaplasia of lactiferous ducts. When squamous metaplasia extends deep into a nipple duct, keratin becomes trapped and accumulates. If the duct ruptures, the ensuing intense inflammatory response to keratin results in an erythematous painful mass. A fistula tract may burrow beneath the smooth muscle of the nipple to open at the edge of the areola. Disorders 1041. Dilation and eventually rupture of the duct. An intense chronic granulomatous inflammatory response develops once keratin spills into the surrounding periductal tissue. With recurrences, a secondary anaerobic bacterial infection may supervene and cause acute inflammation. Simple incision drains the abscess cavity, but the offending keratinizing epithelium remains, and recurrences are common. In most cases, en-bloc surgical removal of the involved duct and contiguous fistula tract is curative. If secondary bacterial infection is present, antibiotics also have a therapeutic role. Duct ectasia. Duct ectasia presents as a palpable periareolar mass that is often associated with thick white nipple secretions and occasionally with skin retraction. Pain and erythema are uncommon. This disorder tends to occur in the 5th or 6th decade of life, usually in multiparous women. Unlike squamous metaplasia of lactiferous ducts, it is not associated with cigarette smoking. Inflammatory. The principal significance of duct ectasia is that it may be difficult to distinguish on clinical and radiologic grounds from invasive carcinoma, fat necrosis. The presentations of fat necrosis are protean and may closely mimic cancer. It may present as a painless palpable mass, skin thickening or retraction, or mammographic densities or calcifications. About half of affected women have a history of breast trauma or surgery. Morphology. Acute lesions may be hemorrhagic and contain central areas of liquefactive fat necrosis with neutrophils and macrophages. Over the next few days, proliferating fibroblasts and chronic inflammatory cells surround the injured area. Subsequently, giant cells, calcifications, and hemosiderin appear, and eventually the lesion is replaced by scar tissue or is encircled and walled off by fibrous tissue. Ill-defined, firm, gray-white nodules containing small chalky white foci are seen grossly. Morphology: lymphocytic mastopathy, sclerosing lymphocytic lobulitis. Ectatic dilated ducts are filled with inspissated secretions and numerous lipid-laden macrophages. With duct rupture, a marked periductal and interstitial chronic inflammatory reaction ensues, consisting of lymphocytes, macrophages, and variable numbers of plasma cells. Figure 23.4. Granulomas may form around cholesterol deposits and secretions. Subsequent fibrosis produces an irregular mass with skin and nipple retraction. This condition presents with single or multiple hard palpable masses, or mammographic densities. The masses are associated with areas of densely collagenized stroma, a feature that may make it difficult to obtain lesional tissue by needle biopsy. Within the stroma are atrophic ducts and lobules with thickened basement membranes that are surrounded by a prominent lymphocytic infiltrate. This condition is most common in women with type 1 insulin-dependent diabetes or autoimmune thyroid disease and is hypothesized to have an autoimmune basis. Its only clinical significance is that it must be distinguished from breast cancer. Granulomatous mastitis, figure 23.4, duct ectasia. Chronic inflammation and fibrosis surround an ectatic duct filled with inspissated debris. The fibrotic response can produce a firm, irregular mass that mimics invasive carcinoma on palpation or mammogram. Granulomatous inflammation of the breast may be a manifestation of systemic granulomatous diseases, e.g., granulomatosis with polyangiitis, sarcoidosis, tuberculosis, or of inflammatory or infectious disorders that are localized to the breast. Granulomatous lobular mastitis is an uncommon disease that occurs only in Paris women. The granulomas are closely associated with lobules and may contain lipid vacuoles surrounded by neutrophils. A similar histologic pattern is seen in cystic neutrophilic granulomatous mastitis, which is often caused by lepophilic corinum bacteria. These histologic patterns may be manifestations of the same disease. Treatment includes antibiotics and sometimes steroids. Localized infections by mycobacteria or fungi are very rare and are most common in immunocompromised patients or adjacent to foreign objects such as breast prostheses or nipple piercings. 1042, Chapter 23, The Breast. Key concepts: inflammatory disorders. Inflammatory diseases of the breast are rare outside of the lactational period. The specific cause must be determined, as appropriate treatment may be antibiotics, steroids, or surgery. The possibility of inflammatory carcinoma mimicking a non-neoplastic inflammatory disorder should always be considered. B. Benign epithelial lesions. Benign epithelial lesions are classified into three groups, each with a different risk for subsequent development of breast cancer. 1. Non-proliferative breast changes. 2. Proliferative breast disease. And 3. Atypical hyperplasia. Most come to clinical attention when detected by mammography or as incidental findings in surgical specimens. Non-proliferative breast changes, fibrocystic changes. This group includes common morphologic alterations that are often grouped under the term fibrocystic changes. To the clinician, the term might mean lumpy, bumpy breasts on palpation. To the radiologist, a dense breast with cysts. And to the pathologist, benign histologic findings. These lesions are termed non-proliferative to indicate that they are not associated with an increased risk of breast cancer. This name is somewhat unfortunate because some of these changes do involve increased proliferation and may even be associated with clonal genetic aberrations. See Figure 23, apocrine cysts. A. Clustered, rounded calcifications are seen in a specimen radiograph. B. Gross appearance of typical cysts filled with dark, turbid fluid contents. C. Cysts are lined by apocrine cells with round nuclei and abundant granular cytoplasm. Note the luminal calcifications, which form on secretory debris. Acini are lined by columnar epithelial cells, and calcifications are occasionally present within the lumens. Several other morphologic alterations fall into the category. Morphology of non-proliferative changes. Lactational adenomas present. There are three principal non-proliferative morphologic as palpable masses in pregnant or lactating women and regress changes. 1. Cystic change, often with apocrine metaplasia after cessation of breastfeeding. They consist of normal appearing 2. Fibrosis and 3. Adenosis. Breast tissue with lactational changes. Their name may be A. Cysts. Small cysts form by the dilation of lobules and in turn misnomer, as these lesions may be an exaggerated local response may coalesce to form larger cysts. Unopened cysts contain gestational hormones rather than true neoplasms. Flat epiturbid, semi-translucent brown or blue-colored fluid blue dome thelial atypia is a clonal process characterized by the present cysts Fig. 23.5 billions. Cysts are lined either by a flattened atrophic of dilated acini, and cysts lined by epithelial cells that display mild epithelium or by metaplastic apocrine cells. The latter cells have cytologic atypia. It is associated with deletions of chromosome-abundant granular eosinophilic cytoplasm and closely resembles 16q, and is the earliest morphologically recognizable clonal lesion, the normal apocrine epithelium of sweat glands. Figure 23.5c of the breast. Flat epithelial atypia is often associated with lesions. Calcifications are common, Figure 23.5a. Cysts may cause concern that increase the risk of cancer, e.g., atypical hyperplasia, described when they are solitary and firm. The diagnosis is confirmed by later, but has not been shown to increase risk in isolation. The disappearance of the mass after fine needle aspiration of its contents, fibrosis. Cysts frequently rupture, releasing secretory material into the adjacent stroma. The resulting chronic inflammation, proliferative breast disease, without atypia and fibrosis, contribute to palpable nodularity of the breast. Lesions characterized by proliferation of epithelial cells. Adenosis. Adenosis is defined as an increase in the number without atypia, are associated with a small increase in the avicini per lobule. It is a normal feature of pregnancy. In risk of subsequent carcinoma in either breast. They are common in pregnant women. Adenosis can occur as a focal change. The only detected as mammographic densities, calcifications, or epithelial lesions 1043. A B figure 23.6a normal duct, or acinus, with a single basally located myoepithelial cell layer. Cells with dark, compact nuclei and scant cytoplasm, and single luminal cell layer. Cells with larger open nuclei, small nucleoli, and more abundant cytoplasm. B. Epithelial hyperplasia. The lumen is filled with a heterogeneous mixed population of luminal and myoepithelial cell types. Irregular slit-like fenestrations are prominent at the periphery. Incidental findings in biopsies performed for other reasons. These lesions are considered predictors of risk rather than direct precursors of carcinoma. Morphology. Several morphologically distinct patterns of proliferative breast disease without atypia are recognized. Epithelial hyperplasia. Normal breast ducts and lobules are lined by a double layer of myoepithelial cells and luminal cells, figure 23.6a. In epithelial hyperplasia, increased numbers of both luminal and myoepithelial cell types fill and distend ducts and lobules. Irregular lumens can often be discerned at the periphery of the cellular masses, figure 23.6b. Epithelial hyperplasia is usually an incidental finding, sclerosing adenosis. There are an increased number of acini that are compressed and distorted in the central portion of the lesion. On occasion, stromal fibrosis completely compresses the lumens to create the appearance of solid cords, or double strands of cells, lying within dense stroma, a pattern that superficially resembles invasive carcinoma, figure 23.7. Sclerosing adenosis may come to attention as a palpable mass, a radiologic density, or calcifications. Complex sclerosing lesion. These lesions have components of sclerosing adenosis, papilloma, and epithelial hyperplasia. One member of this group, the radial sclerosing lesion, radial scar, has an irregular shape and closely mimics invasive carcinoma mammographically, grossly, and histologically, figure 23.8. A central nidus of entrapped glands in a hyalinized stroma is surrounded by long radiating projections into stroma. The term radial scar is a misnomer, as it is not associated with prior trauma or surgery. Papilloma. Papillomas grow within a dilated duct and are composed of multiple branching fibrovascular cores, figure 23.9. Epithelial hyperplasia and apocrine metaplasia are frequently present. Large duct papillomas are situated in the lactiferous, figure 23.7 sclerosing adenosis. The involved terminal duct lobular unit is enlarged, and the acini are compressed and distorted by dense stroma. Calcifications are present within some of the lumens. Unlike carcinomas, the acini are arranged in a swirling pattern, and the outer border is well circumscribed. Sinuses of the nipple and are usually solitary. Small duct papillomas are commonly multiple and located deeper within the ductal system. More than 80% of large duct papillomas produce a nipple discharge, which may be bloody due to torsion of the stalk, leading to infarction. Serous discharge results from intermittent blockage and release of normal breast secretions or irritation of the duct by the papilloma. Most small duct papillomas come to clinical attention as small palpable masses, or as densities or calcifications seen on mammograms. Benign. 1044, Chapter 23, the breast. A B, figure 23. Gynecomastia. Breast enlargement in males is due to an increase in the number of ducts accompanied by dense cellular stroma. Lobule formation is absent. See figure 23.8, radial sclerosing lesion. A. Radiograph shows an irregular central mass with long radiodense projections. B. Grossly, the mass appears fibrotic and has irregular borders, but it is not as firm as an invasive carcinoma. C. The mass consists of a central nidus of small tubules entrapped in a densely fibrotic stroma and numerous projections containing epithelium with varying degrees of cyst formation and hyperplasia. Gynecomastia, enlargement of the male breast, is the only benign lesion seen with any frequency in the male breast. It presents as a button-like subareolar enlargement and may be unilateral or bilateral. Microscopically, there is an increase in dense collagenous connective tissue associated with epithelial hyperplasia of the duct lining, figure 23. Lobule formation is almost never observed. Gynecomastia occurs as a result of an imbalance between estrogens, which stimulate breast tissue, and androgens, which counteract these effects. It may appear during puberty, in the very aged, or at any time during adult life when there is cause for hyperestronism. The most important of these is cirrhosis of the liver, since this organ is responsible for metabolizing estrogen. In older males, gynecomastia may stem from a relative increase in estrogens as testicular androgen production falls. Drugs such as alcohol, marijuana, heroin, antiretroviral therapy, and anabolic steroids have been associated with gynecomastia. Rarely, gynecomastia occurs as part of Klinefelter syndrome, XXY karyotype, or in association with functioning testicular neoplasms, such as Leydig cell or Sertoli cell tumors. Proliferative breast disease with atypia, figure 23.9, intraductal papilloma. A central fibrovascular core extends from the wall of a duct. The papillae arborize within the lumen and are lined by myoepithelial and luminal cells. Atypical hyperplasia is a clonal proliferation, having some but not all of the histologic features of carcinoma in situ. It is associated with a moderately increased risk of carcinoma and is divided into two forms, atypical ductal hyperplasia and atypical lobular hyperplasia. Atypical ductal hyperplasia is present in 5% to 17% of specimens from biopsies performed for calcifications. Atypical lobular hyperplasia is an incidental finding and is found in fewer than 5% of biopsies. Benign epithelial lesions 1045, a B, figure 23.1. 1A. Atypical ductal hyperplasia. A duct is filled with a mixed population of cells consisting of oriented columnar cells at the periphery and more rounded cells within the central portion. Although some of the spaces are round and regular, the peripheral spaces are irregular and slit-like. These features are highly atypical, but fall short of a diagnosis of ductal carcinoma in situ. B. Atypical lobular hyperplasia. A population of monomorphic small, round, loosely cohesive cells partially fills a lobule. Although the cells are morphologically identical to the cells of lobular carcinoma in situ, the extent of involvement is not sufficient for this diagnosis. Morphology. Atypical ductal hyperplasia is recognized by its histologic resemblance to DCIS. It consists of a relatively monomorphic proliferation of regularly spaced cells, sometimes forming cribriform spaces. It is distinguished from DCIS in that it only partially fills involved ducts. Figure 23. Atypical lobular hyperplasia consists of cells identical to those of lobular carcinoma, in situ, LCIS, described later. But the cells do not fill or distend more than 50% of the acini within a lobule. Figure 23. B. Atypical ductal hyperplasia and atypical lobular hyperplasia express high levels of estrogen receptor ER, have a low rate of proliferation, and may have acquired chromosomal aberrations such as losses of 16q and 17p or gains of 1q, features also found in low-grade carcinoma in situ and ER-positive invasive breast cancer. Atypical lobular hyperplasia also shows loss of E-cadherin expression, a feature it shares with LCIS discussed later. Table 2.1. Brevin-Vassie East, lesions, and risk, 3D. Ophevaloing, carcinoma, relative risk, absolute, pathologic lesions, lifetime risk. Non-proliferative breast changes mild 1, approximately 3% hyperplasia, ductectasia, cysts, apocrine metaplasia, adenosis, fibroadenoma without complex features. Proliferative disease without atypia, moderate or florid hyperplasia, sclerosing adenosis, complex sclerosing lesion, fibroadenoma with complex features. Proliferative disease with atypia, atypical ductal hyperplasia, atypical lobular hyperplasia, carcinoma in situ, lobular carcinoma in situ, ductal carcinoma in situ. A relative risk is the likelihood of developing invasive carcinoma compared to women without any risk factors. Absolute lifetime risk is the percentage of women expected to develop invasive carcinoma in the absence of an intervention. Approximately 13%, 8-10, approximately 25%, 1.52, approximately 5% clinical significance of benign epithelial changes. Key concepts. Benign epithelial lesions. Benign epithelial lesions usually do not cause symptoms but are frequently detected as mammographic calcifications or densities. The majority are not precursors of cancer. These lesions are classified according to the subsequent risk of cancer in either breast. Although risk reduction can be achieved by surgery or chemoprevention, the majority of women will not develop cancer, and many women choose surveillance instead of intervention. Epidemiologic studies have established the association of benign histologic changes with the later development of invasive cancer. Table 23.1. Proliferative changes are associated with a 1.5 to 2-fold increased risk compared to non-proliferative changes, while proliferative disease with atypia confers a 4 to 5-fold increased risk. Both breasts are at increased risk. Risk reduction can be achieved by bilateral prophylactic mastectomy or treatment with estrogen antagonists, such as tamoxifen. However, fewer than 20% of women with atypical hyperplasia develop breast cancer, and therefore many choose close clinical and radiologic surveillance over intervention. Epithelial. 1046, Chapter 23, The Breast, Carcinoma of the Breast. Breast carcinoma is the most common and deadly malignancy of women globally. Each year, 1.7 million women are diagnosed, and 1 in 3 of those afflicted die of disease. Although the incidence of breast cancer is 4 to 7 times higher in the United States and Europe than elsewhere, the worldwide incidence and mortality is increasing at an alarming rate. And by 2020, it is estimated that 70% of cases will be in lower-income countries. The factors underlying this trend are thought to be social changes that increase breast cancer risk, specifically delayed childbearing, fewer pregnancies, and reduced breastfeeding, combined with a lack of access to optimal health care. The lifetime risk of breast cancer is 1 in 8 for women living to age 90 in the United States. In 2019, over 260,000 women in the United States were diagnosed with invasive breast cancer, and more than 40,000 women died of the disease, a toll among cancers second only to lung cancer. It is both ironic and tragic that a neoplasm arising in an exposed organ, readily accessible to self-examination and clinical surveillance, continues to exact such a heavy toll. All breast cancers can be separated into 3 major groups defined by the expression of 2 proteins, ER and HER2, also known as ERBB2. In this chapter, luminal cancers are defined as being positive for ER and negative for HER2. HER2 cancers are defined as cancers overexpressing HER2 and can be either ER positive or ER negative. Triple negative breast cancers, TNBCs, are cancers that are negative for ER and HER2. These cancers are termed triple negative because they also fail to express progesterone receptor PR, which is under the control of ER. These 3 groups of cancers differ with regard to patient characteristics, pathologic features, treatment response, metastatic patterns, time to relapse, and outcome, and will be discussed in more detail later. However, it is important to note that breast cancer is biologically heterogeneous, and that each of these 3 groups is comprised of numerous clinically important subtypes. Incidence and epidemiology. Breast cancer is rare in women younger than age 25 and increases in incidence rapidly after age 30. Figure 20. The incidence of TNBC and HER2 cancer plateaus in middle age, whereas the incidence of luminal cancer peaks later in life. As a result, TNBCs and HER2 cancers comprise almost half of cancers in young women and fewer than 20% of cancers in older women. Starting in the 1980s, a marked increase in the apparent incidence of breast cancer was noted in older women. This change appears to be attributable to two factors: the introduction of mammographic screening and the increased use of postmenopausal hormonal therapy in older women. After 2000s, the number of newly diagnosed breast cancers fell in older women, probably due to a leveling off of the rate of mammographic screening, approximately 65% to 75% of eligible women, and decreased use of postmenopausal hormone therapy. In contrast, over the same time, the incidence of breast cancer remained relatively constant in younger women. Women, 100,000. Per rate, cancer, breast, 350, 300, 250, 200, 150, 150. Figure 23.1. 2 incidence of luminal or positive, HER2 negative, HER2 positive, and triple negative or negative, HER2 negative breast cancers according to age. Rates are per 100,000 women. Triple negative, solid blue line, and HER2 solid green line cancers have a relatively constant incidence after age 40 years. In contrast, luminal cancers show a marked increase in incidence with age. This increase is greatest for women of European descent, solid yellow line, and less pronounced for women other ethnic backgrounds, African, Hispanic, and Asian, broken yellow line. TNBC, triple negative breast cancer. Breast cancer incidence and biology vary with ethnicity. The incidence of breast cancer is highest in women of European descent. In this group, the average age at diagnosis is 63 years, and only 20% of cases are diagnosed at an age younger than 50 years. In contrast, the average age at diagnosis for women of African descent is 59 years, and 35% of cancers are diagnosed at ages below 50. For Hispanic women, the average age at diagnosis is 56, and 20% are diagnosed at ages below 50. The excess cancers in women of European descent are mostly of luminal type, figure 23.12. Thus, TNBCs and HER2 cancers make up a greater proportion of cancers occurring in other ethnic groups. The risk of death in those who develop invasive breast cancer has gradually declined in both younger and older women, most recently by 1% to 2% per year. The current overall risk of death is about 20%. This decrease is attributed to mammographic screening, as well as to more effective treatment modalities. However, the decline in the death rate has lagged behind in women of African descent who have the highest mortality rate. Although this difference is explained partly by unequal access to care, breast cancers in women of African descent are also more likely to be biologically aggressive, e.g., TNBC, and to fall into molecular subtypes that are difficult to treat. Risk factors. The most important risk factors are gender. 99% of those affected are female, age, lifetime exposure to estrogen, genetic inheritance, and, to a lesser extent, environmental and lifestyle factors. Table 23. There is concern, but no proof, that environmental contaminants, such as organochlorine pesticides and certain plastics, have estrogenic effects on humans that may increase the risk of breast cancer.